I'm really delighted to introduce my colleague Jane Evans to speak to the healthcare audience today. Jane has been an active part of our lean healthcare community here forever in Australia and been a great supporter and colleague of the work that we do. She's also passionate about waste and, so passionate that it's taken over her life, and she's doing a PhD for her sins. So it's really great that she's going to share some of her thoughts and ideas with you. And I think that she's hoping to interact with the audience as well. So over to you, Jane. Welcome to the stage.
Thank you. Can you just a sound check? You can hear me okay?
Yes, I can.
Thank you. Okay, so good morning, everybody. So my name's Jane Evans, and I am the Group Manager of Innovation and Experience at St Vincent's Health Australia. I'm also a doctoral candidate, and I'm completing a PhD with the working title of Measuring and Realising the Financial Impact of PI in Healthcare, or Process Improvement in Healthcare. And at the outset, I just want to note that I'm using the term process improvement to cover sort of all improvement methodologies and approaches, Lean, Six Sigma, quality, total quality management, whatever you want to call it. And that might be the right term or it might be the wrong term, but I've got a few reasons for choosing that term, but I don't want to get into them here because that'll be a whole half an hour conversation on its own. So whenever I use PI, I'm covering any type of improvement or change activity. So I decided to embark on a PhD really to learn more about, firstly, how to do good research. I'm sort of in that pracademic type of space. I'm a practitioner, but I actually really like the academic space. But actually to learn more about this topic, and I'm going to share my screen. And just put in the chat if you can't see it. So I can't actually see the chat, having said that, because I'm... So the next 20 minutes or so, I'm going to tell you the story of my research journey so far, what I've learned and how I've put this story together. So please be a bit gentle because I've actually never put my 5-year journey so far into 20 minutes. So I'm hoping my story sort of makes sense to you all. But I hope you're not joining this session to find out the answer to this question on the screen because the answer is I don't know either, even after 5 years. But I want to share with you what I've learned through my reading, learning, writing and thinking about the question. And maybe you can help me in the quest to understand and start to problem solve it as I get to the end of my presentation. So if you didn't know already, the world has an expenditure problem when it comes to cost in healthcare. Current estimates are that we spend $8 to $10 trillion on healthcare around the world per annum. This data is data that I've got from this policy advice website. Maybe this number's correct or not. It was actually hard to find a total number, but it's probably somewhere in the ballpark. We're going to be at over $10 trillion in 2022. But the current literature, and even literature going back to the 1950s with Joseph Duran, support the estimate that about 30% of the expenditure and the activity adds no value, with a bit of a definition there. So if those figures are to be believed, we've got something like a $3 trillion US healthcare expenditure problem. And this isn't a new or an unknown problem, but so far collective efforts do not seem to have budged it. So do we have a knowing or a doing gap in solving this worldwide problem? And I've got a couple of polls that I just want to get your feedback on, and they should be live in the chat now. And because I can't see, does somebody let me know that they're there?
They're there, Jane.
Awesome. Can you tell me when I'm good to go? And what the answers are? Is it a problem we need to solve? And if it is a problem that we need to solve, do we have a knowing problem, a doing problem, both or neither? Because it's actually something we don't think we should be solving. So what I'm going to do is...
So Jane, did you want some results or not yet?
Yes, please, sir, please.
So I think the votes are still coming in, but if they remain proportional, I think that the majority are thinking that 66% thinks it's both a knowing and a doing problem. And then the next one is 25%, and that's a doing problem. And then no one has voted for it's not a problem.
Excellent. So I'm going to share with you what we currently know about how people are trying to solve this problem. So in 2012, Don Berwick and Andrew Hackbarth from the IHI categorised healthcare waste into 6 domains. They were failure of care delivery, failure of care coordination, over-treatment or low-value care, pricing failure, fraud and abuse, and administrative complexity. Now, as you know, these are different to the our traditional waste domains that we know, but I actually really like this from a specific healthcare concept. And what they did was they searched the literature, and for each domain, they estimated the waste-related costs in that domain, and then they looked at the interventions that were in the literature about how we could reduce those waste-related costs. Then they summed them up and came up with a figure. In 2019, this data was updated by a group from the US, and they used the same calculations. And what they came up with was that in 2019, there was a total of $760 to $935 billion of waste in the US healthcare system. But they didn't calculate, they don't think all of that waste is something we can do anything with. So they looked at each of the interventions in the literature that could potentially save this waste, and they came up with a figure that we have basically a $200 to $300 billion opportunity to reduce waste and improve the cost. So this information's not new. As I said, it started in 2012, and we're now nearly 10 years away from that. So who's doing anything with this information? And I'll come to that shortly. But it's clear that this is not just a problem in the US. The Grattan Institute, a Melbourne-based health policy think tank, produced a report in 2014 called Controlling Costly Care. And in this report, they identify what they term as avoidable costs by each state, and calculated that Australia has a $1 billion healthcare cost reduction opportunity. And I think they called on governments to look at healthcare pricing particularly, and move from a paradigm of what care currently costs to what care should cost, which it aligns really closely with the Berwick-Hackbarth waste of pricing failures. They also call on governments to benchmark hospital expenditure to identify where we have inefficiency, and that use that identification a bit as a benchmark to actually encourage, particularly states, to start to look at how efficient their systems are. But the report also calls on hospitals to get detailed information on their own unexplained costs and use that to help them improve. But it's obviously not as simple as it sounds, because we're actually still not doing anything with that information either. Healthcare is not special, and a recent paper in the Journal of Operations Management looked at non-healthcare industries, and they noted that given the amount of resources companies devote to implementing and operating localised or company-wide improvement systems, a knowledge of financial benefit determination seems clearly warranted. But they found neither frameworks nor formal methodologies for how to undertake financial evaluations of operational gains derived from PI processes such as Lean and Six Sigma. And I think that this consistency is really important. And so all of the people who aren't in healthcare, I'm hoping can help healthcare solve this problem. So solving the problem. Here's a simple model about what we do know. Hospitals are the most costly component of the healthcare system. And of course, there are many factors associated with the financial performance of a hospital besides the volume of waste and processes in care delivery systems. But in fact, in healthcare, often the problem is merely calculating the costs of care, which is our biggest challenge, let alone understanding how we can reduce them. A really simplistic model to solving the healthcare expenditure problem is to just identify waste in processes and clinical care, apply well-known process improvement methods, and then measure and capture the financial impact and the difference between cost. Should note that this process starts with the identification of waste and not the requirement to improve financial performance, which is a really important distinction, especially in healthcare, where talking about dollars and costs are almost a swear word. whereas making people work their work life better through the removal of non-value adding costs and steps is something that staff will engage with. I'm going to go to a more theoretical model, and I really hope that this model is something that people, it's more practical, and I think it's something that people will relate to and should be fairly familiar. So most of us, if you ask them, would know where our low value care is, our high value care is, and a process waste, and what is we need to do to improve. But in healthcare, every idea is a great idea, and we have so many of them to improve that we know we can't work on them all at once. So we've sort of put this through a little bit of a filter or a funnel to prioritise and come up with a process improvement program that is a mixture of a whole range of projects, some of which will be clinical care initiatives and some of which will be process waste reduction initiatives. We then look at each of our projects, and they all have a number of different outcomes that I'm going to just really high level put into buckets of clinical outcomes, financial outcomes, staff outcomes, and other outcomes, which might be sort of organisational, that kind of thing. And again, then collate them. So how do we collate the outcomes of each of those projects into the program collated outcomes? And then how do we translate those at an enterprise level? How do we take all these financial outcomes and actually understand it, whether they've had an impact on our enterprise budget? Not sure why it's doing that. There are actually a range of other conceptual frameworks in the literature. One that's come from the IHI, and that was in 2009. An earlier one from 2006 from Tom Nolan and Maureen Bisignano, also from the IHI. And finally, one fairly recently from really looking at how do we look at improvement and lean and the return on assets from hospital profitability. But the problem with conceptual frameworks are that they are really hard to translate from a conceptual framework into practice. And so whilst we know what to do, that doesn't really help us with actually translating that knowing into doing. So I want to just talk to you a bit now about what we do know about doing. And there's a number of hospitals who've been really open and have published predominantly in the grey literature about their lean journey and its impact on finances. Both Virginia Mason, Denver Health, Intermountain Healthcare, and there are a raft of others, have actually talked about how their lean program has reduced costs. But in their publications, they've not been really clear about how they have actually turned the improvement and reduction in waste into dollars, which is quite understandable because obviously being specific about finances is fairly, I guess, commercial in confidence and sensitive information. But it doesn't help us in knowing that they've done it, in actually knowing how they've done it so we can actually replicate it. So it didn't really help much. So I took a deeper dive into the peer-reviewed published literature to see if anybody has published this information. And what I did was I did a systematic review and looked at really how hospitals have measured and captured financial outcomes really for enterprise financial improvement. I looked at 5 databases, grey literature, and this process of snowballing. I looked at the parameters of, it had to be about healthcare. It had to have a process improvement or some sort of PI method described, and we had to have financial outcomes described. And what I came up with was only 1,334 papers, but of those, only 4 met all the parameters. And what I found was quite interesting that of the 4 papers, 3 were from the US and 1 was from the United Arab Emirates, but they were actually participating in a US-based program through the College of Surgeons. You can see from the table that there was no one paper or hospital that described the financial measurement component of their PI activities and also then had a measured impact at the enterprise level. But what is clear is that to have a financial impact at the enterprise level, you have to take a whole of hospital PI approach. But having said that, none of the hospitals that actually were able to describe an enterprise impact were able to describe their financial methods. The only paper that talked about financial methods description was one that only looked at 3 clinical projects, and they specifically just looked at direct patient care costs. So there was no ability to measure at the enterprise, enterprise impact. Thought it was interesting that 3 of the 4 papers were from the US. Sorry, I need to go back. And I wondered why that might be the case. And I think potentially it's because there is greater financial pressure on the hospitals in the US. So there's potentially a greater will to identify and realise financial benefits from improving the value of care. Also, US hospitals have possibly made greater investment in financial support systems and clinical costing, enabling them to be able to measure and realise the financial impacts from PI better than hospitals from other countries. But also the US healthcare system is largely private and therefore different in terms of its ability to invest in technology systems and people to support PI. So when framing public health policy outside the US, we need to think about the investments in these supporting system structures and people. The implications of this systematic review is that there is no published research on financial benefits measurement and capture at the PI level at the program and its impact at the enterprise level in healthcare. Not surprised, really, and it does really clearly align with the same in manufacturing. So I decided to take a deep dive into one healthcare system to see if I could learn more about what happens in practice and see if I can link that practice with theory. So I undertook a single hospital qualitative case study, but it was a large Australian multi-site health service with a relatively mature PI program. Case studies are a really great approach because they've been effective when seeking to develop theory. An important feature of a case study in this type of methodology is the ability to speak to a range of organisational actors from a variety of roles, hierarchical ranks and areas of the organisation who view this phenomenon from their own diverse perspective. So it's a really good research technique to get that broad view. And I was trying to answer 2 questions. What are the elements of a hospital's ability to measure financial gains? And then what are the elements of a hospital's ability to capture those gains? And I'm making a very clear distinction that measurement and capturing or realising them are 2 different things. And I think what I've found is that there's a lot of, it's quite easy to measure, but to actually capture and realise those gains is a different thing altogether. Quickly, just on methodology, I did some structured interviews of 16 sort of very key participants in the improvement program at this hospital. I chose those the people based on their organisational roles and their ability to respond to the research questions. I recorded and then transcribed all of the interviews and did a content analysis, and then I used documents to just support any of the information that was provided. So what did I find? All those interviewed agreed that there was lots of waste, and they could all identify it. And in fact, just between that group of 16, they named 47 different wastes. Some of them named the same ones, but these were 47 different ones. And I categorised them. I used my own categorisation method for this one because, again, I thought it was a bit simpler than even the Berwick hack bath. But overall, the group estimated that 10 to 50% of the work that was undertaken in that hospital through care and the processes could be waste. So again, that confirms what the literature says. I then sort of wondered what I was going to do with this information. And so I undertook this following exercise to see how those wastes and process improvement could actually impact the finances. And this isn't a validated process. It's one I've sort of a thought process I've done myself. So I'll be interested to see what people think about it. So what I did was I firstly went through each of those wastes to say, is it theoretically avoidable or is it something that we can actually impact? And I got 100% strike rate. I then looked at it from the organisation's control, ability to control it and impact it, and nearly all of it was avoidable except for the other bucket. And in the other bucket, it was generally administrative type of things that related to government policy and process about how we were funded and how we had to provide reporting. And so I think that's a fairly translatable type of bucket relating to any health policy context, I guess. I then looked at whether it was within the organisation's control, but PI methods could actually impact it, because PI can't do everything for every type of waste or problem, but in fact I found most of them could. I then looked at the type of dollars that came from that reduction or change in the level of waste. And in layman's terms, dark green dollars are those that directly impact the financial bottom line and are reflected in the organisation's profit and loss statements. On the contrast to dark green dollars are light green dollars, and they can be thought of as things such as efficiency or productivity gains, where the hospital is able to treat more patients within the same expenditure envelope. But it is possible to turn light green dollars into dark green dollars. For example, efficiency gains can be used to reduce staffing and overhead costs rather than treating more patients. So I looked at which of those wastes where there was light green dollars could actually be converted to dark green. And finally, I looked at the type of financial impact that would arise. So whether it was just reducing costs, creating new revenue streams, producing efficiencies, improving profit margins, creating capacity, of which we could do whatever we liked with it, and then avoiding costs. So there's no necessarily science behind this, but I think it was a really good thought experiment from this exercise. And what I did find was that, yes, hospitals can use PI to reduce or remove waste with a resultant financial impact at the enterprise level, but we don't necessarily do it. Key success factors was what I was looking for in this case study to find out what it would take to address it. And these are the key things that I found. I separated them into technical and social. The technical things, are things that we can address ourselves. They are not necessarily easy to do, and they can cost money, but they're things that we can do. The social is where we have the challenge, and I think that's we heard a bit about that this morning about behaviours with the two Nigels talk. A couple of things that I just want to point out here. One is that the word accountability was used by a number of interviewees, particularly in relation to unclear or indeterminate accountability for expenditure, particularly at the patient level. So who is responsible for ensuring that we are budget conscious and cost conscious when we're delivering patient care? And some of that's potentially that there are inadequate cost controls being applied at the patient care delivery level. We often need to think about the motivation of individuals, and in healthcare, clinicians, particularly working in a public hospital, are deeply motivated to care for patients, and so we're not concerned about the money or the financial outcome of the care provided. The political or policy context and environment was also really important, because regardless of whether it's government funded like in Australia and the UK, or the US being responsible and having your insurance companies there, we all have standards and legislations that we have to meet. And a lot of staff time is directed towards compliance activities that doesn't always add value to the patient and can take up valuable staff time around reporting and repeating the same information over and over. I think Berwick and Hackbarth called that administrative complexity. So I think we seem to have a doing problem. And we've got one more poll here that I'd just love to get your views on. And Lisa, if you can put that forward, that'd be great.
You see
Denise,
that?
And Denise, can you read it out to me when we've got the answers?
Sure, we can see it. I'm just trying to decide what to answer at the moment.
I don't know if you can answer more than once. Does a poll allow you to have multiple answers?
No, it's like you've got to take your most, I think, your strongest thinking. I don't think you can answer. No, I don't think you can. Okay, we've got a pretty mixed bag on this one, Jane.
It's good.
The votes are, I think people are, probably would like to click more than one answer, which I think is interesting, because if we think about, like, how do we start to address this problem?
Correct.
How do we start to break down this great big slab of concrete and start to progress? What would that look like? So at the moment, we've got at 45%, we know how to capture financial outcomes, but need more resources. And then the next one after that is we capture financial outcomes, but we haven't published.
Oh, that's interesting.
Yeah. What are your thoughts?
So I'll keep going to the end.
Right.
Because I think it sort of answers my thoughts, I think, because we all know where the waste is. I think nobody would disagree that we know where the waste is, and that we all have significant amount. And we know whether PI is the right approach to impact that waste. And we know what type of financial impact and actually how to measure it. So I want to know why we're not. I just really want to know why, and why is not a good question from a research perspective. You can have a what and a how, but a why question doesn't work. So this is where I'm sort of in this limbo between the practitioner and the academic. There are quite a few people in the literature who have come up with whys about the complexity of our healthcare system, that we generally have efficiency gains in predominantly, and we put it towards treating more patients. We have large fixed costs in hospitals, so we often can't realise savings. Medical staff potentially aren't aware of their role, and as I've found before, they don't necessarily think they put clinical care ahead. It's a lack of evidence of the impact that PI can have on financial performance at that enterprise level. I love this one. We may yet have not currently developed a sense of embarrassment about the levels of waste. Variable costs that can be impacted are a much smaller percentage of overall expenditure. The waste itself may not be able to be impacted by PI, or health system policy and environment, and may not support and actively work against waste removal and reduction. And all of those thoughts have come from the published literature. So it's good to know that the things that I'm finding are not new, they're not unknown, but we've still not been able to tackle any of these things. So what I do know, and this is my last slide, is that every system's perfectly designed to get the results it gets. So we haven't changed the system. Nobody's really been able to change that system. So we're going to continue to have a worldwide healthcare expenditure problem that at some point is, and I don't know what that point is, that is going to actually come back to I guess, bite us. But if we do nothing, nothing will change. And someone has to take the lead to solve this problem. So it's if it's not you, then who? If it's not now, then when? Who's with me? And that's, I need to know work out how to unshare.
I think you've done it, Jane.
Perfect.
And you're getting full marks on your ability to run that technology today. Fantastic presentation. I think really thought-provoking. There's a couple of comments. We don't have any questions in the Q&A, but there are a couple of comments there. Alice is wondering whether other sectors do better with costing waste and its elimination. And I think earlier in your presentation, you alluded to the fact that they don't. Would you want to comment a little bit on that?
Yeah, there was this great paper, as I said, that's in the Journal of Operations Management, where they did a similar thing that I've done, and I only literally found it about 2 weeks ago. So I've done all of my research on this, but it was published in 2021 as well. So it's a very recent paper where this group have tried to do exactly the same thing as I've done, and found exactly the same thing. So when we're looking at not using lean or process improvement to drive down cost, but saying we're trying to reduce waste, and we know that waste costs money. If we look at Porter's value equation of outcomes per dollar spent, that value necessarily has a cost associated with it. So if we're going to measure outcomes, we should be measuring cost and dollars to create that value. So effectively the literature is telling us that it's not just a healthcare problem. And yes, I would love to collaborate with somebody, anybody.
Thanks, Jane. I think the real benefit of these sessions is that, people, we learn about what each other's interest areas are, and I'm sure we've all learned a lot already today. And particularly for healthcare, we often have these conferences together. So it's great to have this connection event where we can access material from other sectors to see how it will help. So Jane, thanks again. Looking forward to you progressing this journey in your greenfield site. If I'd had longer to ask you what you were going to do, now you're getting the chance to design over again, but we'll leave that to another day. Thank you.
Thanks everyone for listening.
Thanks, Jane.